Welcome to Roadmap to Residency Evidence-Based Application. In this video, we will be discussing some questions with you guys about neoplasia and tumor growth. So here we have a question with us. A mutation in which of the following genes is most likely responsible for this patient's condition? A 38-year-old man is evaluated for blood stools, weight loss, and anemia. The patient's past medical history is unremarkable, and he does not take any medications. He uses tobacco and drinks alcohol socially. The patient's father died of colon cancer at age of 40. His younger sister suffers from endometrial cancer. An examination is remarkable for the minimal right-sided abdominal tenderness without guarding to deep palpation. Stool is positive for occult blood. Colonoscopy shows a right-sided ulcerative colon mass. No polyps are noted. Biopsy of the mass reveals adenocarcinoma. A mutation in which of the following genes is most likely responsible for this patient's condition? APC, BRCA1, MAIN1, MSS2, or von Hippel-Lindau. Now, this is a gastrointestinal integration of the neoplasia topic. So this case is typical for hereditary non-polyposis colon cancer or Lean syndrome, which is an autosomal dominant genetic predisposition to colon cancer. In patients with HNPCC, colon cancer occurs at a young age of less than 50. Now, family history reveals a high incidence of colon cancer and occasionally extraintestinal cancers in first-degree relatives. With HNPCC, there is an inherited mutation in one of the genes responsible for DNA mismatch repair. The products of these genes proofread the DNA during replication, and patients with HNPCC inherit a mutation in an allele, and mutation of the second allele occurs during adult life. Now, when these two dysfunctional copies are present, malignancies will develop readily. Here we have one more question with us. So which of the following is the most likely origin of the cells detected on the biopsy? A 54-year-old man comes to the office due to a neck mass that has been slowly growing over the past 3 months. The mass is not painful and the patient has had no associated fever or chills but has lost weight. He has no chronic medical conditions and takes no daily medications. He has smoked a pack of cigarettes per day for the past 30 years and has used alcohol occasionally. Physical examination reveals a 2 centimeter hard left-sided supraclavicular lymph node. Biopsy of the lymph node reveals anaplastic cells that are diffusely positive for cytokeratin immunohistochemical stain. Which of the following is the most likely origin of the cells detected on the biopsy? Endothelial cells, epithelial cells, fibroblast, lymphocytes, melanocytes, or muscle cells? So here we have the answer, that is epithelial cells. Now let's go through the explanation. So cytokeratins are proteins that form the intermediate filaments in epithelial cells. Now these intermediate filaments are the stable fibers that extend across the cell cytoplasm and connect to anchoring proteins like desmosomes and hemidesmosomes in the plasma membrane, therefore supplying cells with structural support to withstand mechanical forces. The patients that compose these intermediate, the proteins that compose these intermediate filaments vary based on tissue type. Now, detecting antigens that are specific to certain tissues can help characterize the origin of neoplastic cells in some undifferentiated tumors. For example, a tumor that is anaplastic in origin. For this reason, the immunohistochemical stains targeting the intermediate filaments proteins are often used to classify tumors. Positivity for these cytokeratin stains suggests that a tumor has epithelial origin, example carcinoma. Now, other intermediate filament proteins that can be targeted to determine a tumor cell origin include desmin, which is muscle cell origin, glial fibrillary acidic protein, which is glial origin, neurofilament, which is neuronal origin, and vimentin, which is fibroblast or mesenchymal in origin. Now let's go through one more question. Now, which of the following features best distinguishes the patient's lesion from cervical malignancy? A 27-year-old woman comes to the office for a health maintenance examination. The patient has no chronic medical conditions and no family history of cancer. She has had several sexual partners and takes OCPs for birth control. Vital signs are normal. Physical examination, including pelvic examination, is normal. A pap test is performed and shows a squamous intraepithelial lesion that is positive for a human papillomavirus. A cervical biopsy is performed and reveals a low-grade dysplasia. Which of the following features best distinguishes this patient's lesion from cervical malignancy? Abundant mitosis, disorder maturation, loss of cell polarity, nuclear abnormalities, neomorphism, reversibility of changes. So, human papillomavirus infection of the cervical squamous epithelium can lead to dysplasia or cervical intraepithelial neoplasia, which is a pre-malignant lesion. Now, this squamous dysplasia is characterized by a breakdown in the normal organized progression from tall cells in the basal layer to flattened cells on the epithelial surface. Now, these individual dysplastic cells are often leiomorphic. Leiomorphic means the shapes and size are different. Every individual cell is different in shape and size, have enlarged and hyperchromatic nuclei, and are associated with numerous mitotic figures. The grade of CIN describes the degree of epithelial disruption. So we have low grade and we have high grade CIN. Now the low grade CIN means that dysplasia have involved only the lower third of the epithelium. Here we can see this is the SPB infection and progression to cervical cancer. So this is the histological part of the normal cervix. We can see the low grade, where the dysplasia has only occurred in less than one third of the epithelium of the cervix. High grade means if it involves more than one third of the total squamous epithelial surface. And invasive means when it just invades the basement membranes. Now, let's go through one more question. So, which of the following is the most likely function of the protein affected by this patient's gene mutation? A 4-year-old girl is brought to the clinic due to an inward deviated right eye. Examination shows a pale red reflex in the right eye relative to the left eye. Dilated fundoscopic examination reveals a well-circumscribed white mass within the retina. Genetic analysis shows a germline mutation in the patient's cells, leading to development of the mass. Which of the following is the most likely function of the protein affected by the patient's gene mutation? Activation of receptor tyrosine kinase, conversion of GTP to GDP, opposition of p53 activity, prevention of the G1S cell cycle transition, or repair of the damaged DNA. So these patients pale red reflex and well circumscribed white mass within the retina are indicative of retinoblastoma. Retinoblastoma is an intraocular tumor caused by inactivating mutations affecting the RB1 tumor suppressor gene with subsequent dysregulation of the cell cycle. Now, the cell cycle consists of phases like G0 phase, S phase, G0 phase, G1 phase, S phase, and the G2 phase. Now you can see this is the typical picture of the cell cycle. Now in the G0 phase, there is the cell cycle arrest. That means that the cell are in the resting phase and they can be activated. Now when these cells get activated, it enters the G1 phase. Now G1 phase is when there is a pre-synthetic growth or organelle duplication. There is not multiplication of cells, but the cell prepares for the replication. The cell prepares for the synthesis phase. Now, the synthesis phase, also called as the S phase, is where the DNA replication occur. Now, there is a checkpoint between the G1 phase and the S phase, which is by the RB protein, or which is also called as the G1 S phase checkpoint. Now, you can see that whenever this RB protein, this mutation in this RB protein, there is no checkpoint. It means that the cells can indefinitely go towards the S phase. There is no regulation, so there is uncontrolled growth of the cells. That's how tumor develops. Also, there is a G2M phase, a checkpoint, which inhibits the transition from the G2 phase towards the M phase. You know that the G2 phase is a pre-mitotic growth DNA is where there is a pre-mitotic growth and the DNA damage repair occurs. Now, when there is no checkpoint for the G2 and M phase, the cells can indefinitely go for the cell division. Now, this is a typical cell cycle, and it is very important to understand this cycle for the oncology part. Please remember the G1S phase checkpoint and the G2M phase checkpoint. Now, let's talk in brief about the features between the benign and malignant tumors. Now, the benign tumors are well circumscribed and sometimes encapsulated, whereas the malignant tumors are poorly circumscribed and they penetrate the capsule if it is present. The benign tumors are non-invasive, whereas malignant tumors can invade into the adjacent tissues, lymphatics, and vasculature. Obviously, there will be no metastasis in case of benign tumors, whereas there is extensive metastasis in case of malignant tumors. The tissue structures are organized in case of benign, where it is poorly organized in case of malignant. Now, the lung cancer to brain metastasis is a very typical form of metastasis that almost a very wide variety of tumor follows. So we will just take it as a reference point to understand the metastasis pathway of different cancers. So whenever there is a primary tumor, if it is malignant in origin, then it can go to invasion into the tumor environment. After that, there comes the intravasation. Intravasation means that the tumor cells now have entered the blood capillaries. Now, after the intravasation, these tumor cells can circulate and go towards different body parts. For example, in this case, the lung cancer goes towards the brain. Now, when it reaches the blood vessels of the brain, it attaches to the integrin. Remember, we have talked about the selectins and all. It is just like that, the integrin. This integrin gets attached to these tumor cells, which is called as the adhesion. And through the capillary dilation or constriction, now there is this extravasation, that is the tumor cell escapes the blood capillaries, and when it escapes the blood capillaries, it can go towards some micrometastasis. Now these micrometastasis will cause the neuroinflammatory response. Now this micrometastasis is due to the proliferation of the original tumor cells that have migrated there. Then these micrometastasis can further go on to reside there, which is called as the colonization through metabolic reprogramming. Now, this is the typical pathway of lung cancer to brain metastasis, and this pathway is typically followed by almost a wide variety of tumor cells. Thank you for watching. Keep studying hard.